Thank you all very much for the invitation. It is an honor to be here and to celebrate with this annual Norman Seay lecture. It is a wonderful thing that you are doing here. The way that you are reaching out to the community, the way the community is embracing you back is a special thing. And so it is my privilege to be able to take part of this event, to participate in this engagement, and to provide a little bit of my perspective on what is happening in Alzheimer's disease. And yes, I have to certainly acknowledge all of those that came before me that have enabled me to get as far as I have. The generation that really knocked down the doors, that took that path to the wilderness and paved a trail, have enabled me to move so much faster to get ahead so that we can make contributions that benefit everybody. And so what I'm going to be doing in the next half an hour or so is talking about exploring brain complexity and other insights into Alzheimer's disease. It is taking all these different types of training that I have been through, the undergraduate engineering, the graduate school in neuroscience, the computational neuroscience, as well as the clinical neurology, and trying to find ways to bring these together to help with the diagnosis of this dreaded disease, help with following progression of it, trying to find new ways of using the information that we have to enable us to be better clinicians. And here, so this is a CME talk, so slide 2 has my disclosure slide, of course. So there are a number of clinical trials that we are running at the University of Utah that are mostly involving new pharmaceutical agents in Alzheimer's disease that provide some funding that's supporting me. I've gotten support from the Center for Alzheimer's Care, Imaging, and Research, which is led by Dr. Norman Foster at the University of Utah. And I have a K-23 grant from the National Institute of Aging that has provided tremendous support over the past couple of years. No stocks or equity in pharmaceutical companies. So that's out of the way. So here's the outline of the talks. I'm going to talk a little bit about Alzheimer's disease so that we're all on the same page. I think a lot of people use these terms in different ways or in ambiguous ways, so it's important that we all talk about the same thing in the same way as best we can. I'm going to discuss neuroimaging findings as it pertains to Alzheimer's disease. How do we use neuroimaging, types of neuroimaging? And this is not meant to be a comprehensive review because that would be a semester course and there really isn't fully time for that. But I'll hit some of the highlights of the ones that are, I think, most interesting and show the most promise. I'm going to discuss some of my particular work on fractal analysis and then tie that into clinical trials and the quest for new information, the discovery of new ways of treating this disease, better ways, because the treatments that we have now we know are just not good enough. They're beneficial, they're measurable, they help, they don't change the underlying disease course. We need better therapies for this disease, and this is how we get there. And how do we encourage the population of diverse individuals to participate so that we can generalize the information down there. So it's a lot to cover in half an hour. I'm not a very formal person, so certainly if you have any questions about what I'm talking about, you can chime in. I'll leave some space for questions at the end as well. And of course, I'll be around all day, so if you have other questions, you can do that. So one of the most common questions that I get when I come to clinic, or even just any talk, is like, what is the difference between dementia and Alzheimer's disease? People use dementia in all kinds of different ways, talk about Alzheimer's as if it's a normal part of aging, but when I'm talking about dementia, I'm going to refer to this particular definition from Diagnostic and Statistical Manual version 4, which is already obsolete, but I thought it was a good place to start. It's really understandable. So when somebody says that an individual has dementia, what they mean typically is that they have memory loss. They have one or more disturbances in other aspects of functioning, because doctors like to talk in Greek, and so we use words like aphasia and apraxia. So an aphasia is a disorder of learned language, and apraxia is a disorder of a learned skill, learned movement. There's all different types of apraxia, and you can get really into that sort of behavioral neurology talk, but it's not, so I'll just keep it simple. Disturbance in executive function, so things like planning, like multitasking, and difficulty in the awareness of your own deficit, so this agnosia. So these are all features that can characterize a dementia syndrome. Dementia is not specific, so dementia is really more of a description than a diagnosis. It's like saying somebody has a headache, but Why do they have a headache? Is it because they have a brain tumor or because they have a migraine? So similarly, a person can have dementia. Is it because they have a progressive neurodegenerative disorder like Alzheimer's, or maybe because they have depression? Maybe they have vitamin deficiency. Maybe they have kidney dysfunction, liver. There can be lots of reasons a person can have a clinical dementia syndrome. And what we need to do is to define the cause of that and then work specifically on treating that cause. In order to meet criteria for dementia, typically it has to have impairments in daily functioning. And there are a number of causes. We are focusing mostly on Alzheimer's disease today, and that's largely because Alzheimer's is the most common. Especially in individuals over the age of 65, Alzheimer's disease is the most common cause of dementia. And there has been an explosion of information in the past couple of decades looking as to what is the cause and understanding the neurophysiology of it. Okay, so Alzheimer's disease, of course, so some of the earliest characterizations came from a German physician named Alois Alzheimer back in 1906. Some of y'all get that. If you don't get that, you can ask your friends what that means. But yeah, again, most common over the age of 65. The incidence varies. And actually, these numbers are actually old now. These are numbers from the Alzheimer's Association from about 2 or 3 years ago, and they come out with new numbers every year. The numbers are growing. Suffice it to say, this disease is expanding rapidly as the population ages. More and more people are developing. The incidence and prevalence are both rapidly growing. The cost is overwhelming. Some estimate now the number is up to 5 million cases by the year 2040. Cost over $100 billion. Clinical features, I mentioned a few of those. Okay, so animation, kind of, or little picture graph. So the main features that we're talking about in Alzheimer's disease, so on the left side of your picture is a cartoon where these neurons are really sparsely drawn on there. But the two clinical pathologies that you see in Alzheimer's disease are the amyloid plaques. So amyloid is an accumulation of protein. In this case, it's a particular protein called beta amyloid that has a particular length and a particular pattern of amino acids that we can identify. And it forms these plaques in between cells that are toxic. And then inside the cells, there are accumulation of these neurofibrillary tangles. These are composed of a protein called tau that's a normal part of a cytoskeleton. It gets phosphorylated, and it tends to break down and form clumps inside the cell, also toxic. So those are the two hallmarks on there. So the criteria are interesting in that they are evolving a bit. So it used to be that you had to have a clinical dementia syndrome in order to be diagnosed with Alzheimer's disease. That notion is really changing because of the new neuroimaging techniques that we have available. So that beta amyloid, it used to be, 10 years ago, the only way you'd ever really know for sure is by autopsy, but now there are ways of imaging that amyloid protein in awake behaving people, and we've discovered a lot of interesting insights that I'll mention in a minute, but suffice it to say, this is an evolving definition, evolving criterion, and there are people in the room who are actively involved in changing these diagnostic criteria. So. Trying to understand what's happening. So the pathologic identification is still the gold standard. And so the only way to get definite Alzheimer's disease is to look at a piece of tissue under the microscope. There are cases that follow the classic kind of bread and butter presentation, who don't have any other explanation, who fit biomarker investigation, and for those you can call them probable. But unfortunately, there are a lot of people that have a number of illnesses. And so microvascular disease, where you have wear and tear on your brain from things like hypertension, hyperlipidemia, diabetes, is very common and probably increasingly common amongst African Americans. I know certainly when I was in Dallas and I was looking at brain images, there was a much higher incidence of wear and tear than I'm actually seeing in the population where I am in Utah. So definitely there are ethnic and geographic differences in those risk factors, but it's rare that you get a clean case. You kind of treasure those clean cases from a scientific point of view, But if you want to ask questions about what actually happens with real people who have multiple diseases, you have to do it in a clinical population, which is a whole new kind of different ball of wax, and we're just getting that part started. Okay, so why do we bother with imaging on here? So there's a couple aspects here. The role of neuroimaging in Alzheimer's disease. So everybody that comes to my clinic gets some picture of their brain, most commonly an MRI, most commonly a biomarker quality Alzheimer's disease neuroimaging initiative calibrated, very finely tuned scan. That allows me to look at the structure, and you can rule out a number of other possible causes for their cognitive disorder. So important as a rule out. And so the MRI can be supportive. The MRI is never going to be enough in and of itself, but it plays an important role in the diagnostic process. There are occasions where the diagnosis, despite having good neuropsych data, having good laboratory evaluation, an MRI is still ambiguous. And so FDG stands for fluorodeoxyglucose. It is a way of measuring brain metabolism. That test is FDA approved for distinguishing between frontotemporal dementia and Alzheimer's disease. These are different causes that can sometimes overlap, but the way in which those diseases respond to medication is different. And if you wanted to enroll somebody in a trial that is targeting the specific cause of Alzheimer's, you better make sure they don't have some other pathology causing that, because your likelihood of that drug working is almost zero, and it has side effects. So being very pathologically driven and specific is important, especially as our targets become more pathologically specific.
Before you leave the slide,
yes.
You said you fine-tune the MRI. What does that mean?
Oh, okay, sure. Yeah, that was a lot to say in one sentence. So there is a study. So this is not my study. This is a nationwide study that's probably closer to, it's almost 10 years old, Adney?
It's over 10 years.
Over 10 years old. So this is the Alzheimer's Disease Neuroimaging Initiative. It was a large study funded as a combination of National Institute of Aging, other National Institute groups, and private companies, designed to standardize the approach to doing an image. So it's amazing in that if you look back 20 years ago at MRIs, that the quality varies dramatically between different scanners. So different companies make different MRI scanners. And in the scanner, you have a head coil that you put, that's used to obtain data. You have what's called pulse sequences that are used to determine what type of information you're trying to gain. And they were all different. And so this study looked at how do we optimize that. And so because of that study, now just about everybody is using a compatible and much more agreeable protocol, even across different institutions. So there's a specific protocol for every type of MRI scanner, for every type of head coil, that allow you to get really beautiful pictures of the brain. And so I'm standing on those shoulders too, so I'm using that protocol. Not everybody uses it though. Most places, like big institutions, use it, but even in the community, oftentimes at somebody's private MRI facility, they may or may not use it. So we're trying to get it to be incorporated more broadly because it gives us such great information.
It's understood that you're all looking at the same thing, or looking for the same thing, or you're looking for what might be there?
So we are looking at similar things. Most of the time we have a general hypothesis that is the same. Occasionally you may have a specific cause, and that has to do with the clinical presentation. So if you think somebody might have a stroke syndrome, of course, you're going to look very carefully to find those. If you think somebody had a recent infection that's causing changes in what's called the limbic system, you might look for those. So there certainly can be specific causes, but this gives us a way to actually get different images from different places and do the same analysis on them in a reliable and repeatable. And otherwise, if you had a scanner from here and a scanner from Mayo and a scanner from Houston and put them in the same database, they wouldn't be able to be used for one analysis because they're so different. Now they're the same, or at least similar enough that we can do the analysis. Okay, so mentioned FDG PET, and even more recently, there has been the development of what's called amyloid PET. So amyloid, of course, is that marker in Alzheimer's disease. We now have ways of imaging that essentially directly. So the marker sticks to the amyloid protein, and you can measure how much of it is present in the cortex. And the image correlates quite well with the pathology when we look at it under a microscope. So new tools. I wish amyloid PET were available for everybody all the time, because I would love to use it. Unfortunately, it's not reimbursed by insurance companies at the moment, and reimbursement in a lot of ways drives medicine in ways that are a bit unfortunate, but you have to be realistic about it, that this is a $1,000 scan. You can't just scan everybody that walks in the door if there's no way to pay for it. So many places are able to pay for it through research funding. That's wonderful, but not everybody has that. And so we are trying to get that type of scan covered. And
Dr. King,
yes.
FDG PET scan
Yes.
is still primarily a research tool?
No, well, it is used in research. In the right clinical setting, it has FDA approval to be used on anybody. And that's primarily where you have a dementia syndrome present. You don't know what the cause is, despite having the MRI, the neuropsych testing in the labs. And so that test helps to differentiate, in particular, frontotemporal dementia from Alzheimer's disease. So that's the role that it has in this type of testing. Of course, that test is used for many other things, like people who have cancer, you'll get a body scan looking for places that are hyperactive. But in this case, we're looking at brain metabolism, and in that context, it has the best and most clear application. Okay, so I mentioned getting the MRI to look for other causes. So this is just showing in MRI that there's something else on. It may not be so obvious on the left side here. It's there if you're looking for it. But this is a patient who has a giant meningioma on the left side of the brain, because this is radiology convention, so left is right and right is left on here. So this is a tumor of the lining of the brain that's actually outside of the brain and squishing the brain out of the way, and it happens to be right in the regions where the memory centers are located. So a patient like this, especially if they were left hemisphere dominant for language, could have quite a few memory symptoms that might look very similar to a person with Alzheimer's, but very different cause. Don't want to miss those. This is another MRI. This time I've changed the direction, so this is the top of the head here, and you're taking slices that are coronal. What this is showing is that the temporal lobe here, this is right behind the temples, has dramatic asymmetry. So this is a person who most likely has a frontotemporal dementia, not so much an Alzheimer's disease. And so, again, you want to identify these changes. MRI is good for that. Okay. Couple of other interesting structural findings there. Anybody want to jump in what that is? Any of you clinical people, neurologists there? Yeah. No. The cerebellum kind of gives it away. So on the gradient echo, there's a number of microbleeds in the cerebellum. So this is an individual who probably has cerebral amyloid angiopathy. So they have multiple microbleeds. And that can also present as a dementia syndrome, but different underlying course, different management. So, good. So structural imaging plays a role in certain all these. In addition to the rule out of other things, there are changes in the shape of the brain, in the volume of the brain, that are associated with different diseases. So what I'm showing on this slide is, on the left is a cartoon of a normal brain. And so there are a number of anatomical features that we can identify in terms of how big of the fluid space is in the middle. Those are the ventricles. Go back. The folds and curves of the brain will change over time. So the fold is the gyrus, and then this kind of curve in between is the sulcus. We can look at the size of those, and that has a lot to do with the research that I've been doing, is trying to quantify some of those shape metrics on there. Good. So here are 3 coronal MRIs, all the same age but different clinical presentation. On the left is a picture of a healthy individual, global cognition. In the middle is a person with a mild impairment, or maybe a CDR of 0.5. And then on the right is an individual who has a neurodegenerative process that has led to a clinical dementia syndrome. In this case, Alzheimer's disease was most likely. So there are structural differences you can quantify, and we'd like to know, how do we use those? So one of the questions is, does atrophy equal dementia? Can you look at a scan and tell me what the clinical presentation is? And so it's a bit more complicated than that. So what you're looking at, so on the left So these 4 images, so 2 axial slices, 2 coronal slices from one individual, and then on the right are 2 axial, 2 coronal from a different individual. And what you see on the right, so these are skull stripped images, so the skull is missing, the brain is missing, and the amount of atrophy on the brain on the right is certainly more on the left. But which one has the problem? Well, it turns out on the left, and these are from Denise Park's data. She's doing a longitudinal, well, some of this is from her data, some of this is actually from ADNI. So on the left is a young individual who has clinical Alzheimer's disease, and on the right is an older individual who's clinically normal. So atrophy in and of itself is not specific or sufficient to diagnose dementia. It is a more complicated process that also involves aging as it's going through. So talking about the other markers, I wanted to mention the PET studies in a little bit more detail. So PET stands for positron emission tomography. I had mentioned before the fluorodeoxyglucose as a measure. You also can use the amyloid markers as a measure. There are a number of other measures that are out there, everything from O15 water. I think Dr. Bateman's been quite involved with that. There are studies using carbon or fluorine. There are a number of different agents that you can use. And I just learned that your institution has like 4 cyclotrons on here. That's amazing. We have 1 at the Huntsman in Utah, and we're all super proud of that. It's like, oh, we've got 4, and there's 2 over here, and there's 1 downstairs, and we just go get it whenever we want it. And it's like, oh, okay. It's terrific. Good. So this is a picture of the fluorodeoxyglucose uptake. Don't have the scale bar on there, unfortunately, but what you're looking at on the right side are the top 2 are axial slices of an individual who's normal, and so it's the rainbow scale with the red being most active. What you're seeing is that the normal has a much higher uptake than the individual with Alzheimer's disease, where the colors shift on the cortex to more yellowish green because there's less uptake. Okay, so how do we use this? How can we use this to explore Alzheimer's disease? So one of the features of the FDG PET is that it picks up cases that people thought were Alzheimer's but that probably aren't. Okay. So this particular study is taking that same Alzheimer's disease neuroimaging initiative, and so individuals in that study everybody got an MRI, everybody got the neuropsych battery. A subset of them also got this FDG PET scan. And when we did the analysis looking at them, what we found is that even though this is a highly selective, very carefully characterized group, and we thought for sure clinically that everybody has Alzheimer's disease, when you look at the pattern on their PET scan of the metabolism, that there are several who have a pattern that looks more like a different disease. Like we see, in this case, I had 91 individuals that were taken from the ADNI, the Alzheimer's Disease Neuroimaging Initiative database, and like 61 of them looked like Alzheimer's disease, and about 15 had a pattern that looked more like FTD. So even in our best characterized studies, there's a prevalence of disease that is higher than we might expect. I think we're not quite as good at making this diagnosis as we might think we are just on a clinical basis. So this table is showing you some of the demographics. So there were 61s whose the pattern I'm showing is this first row. 61 of them had a pattern that was more like Alzheimer's disease, which you would expect that all of them would, but only 61 did. 15 of them had a pattern that looked more like frontotemporal dementia. And so what this is saying is that when you are doing a clinical trial, it is critical that you have some other marker besides the clinical presentation to use as a biomarker of do they have Alzheimer's disease or not, because just the clinical presentation, you're going to probably be wrong somewhere 10-15% of the time. And this has been found not only on the imaging studies, but also on pathology. For those that actually have an autopsy afterwards, there's a fairly high incidence of individuals who don't have that amyloid pathology when you look at the autopsy. And you don't want to wait until getting the autopsy to make this diagnosis correctly. So another important role for bioengineering, another important role for neuroimaging in this process. Good. So there are a number of ligands for PET. I'm going to speed through that one because I'm going too slowly. Good. Okay, so in addition to the FDG and the amyloid, of course, you can look at the structure of the brain itself. So this video is showing what happens to the structure of the brain. This is looking at cortical thickness over time. And so this is from the Laboratory on Neuroimaging, because that's now at USC. So this is waves of loss. So these are serial scans of individuals showing the change in cortical thickness over time. So you can see that, right? So there definitely are changes that occur in the shape and the volume of the brain over time. Yes? So I believe that those were done over about 10 years in serial slices. Okay. And so several groups have been looking at structural imaging biomarkers on there, and this is also from Thompson and Toga group, because they make such great pictures out there. But suffice it to say, this is a useful way, and I want to try to take advantage of that and take it to the next level. So some of my research then, so for the next couple of minutes, I'm going to talk about this complexity measure. So I've been trying to develop a novel way of identifying differences in the shape of the brain in patients who have neurodegenerative disease, as well as looking at it in normal aging. So we're using this method called fractal analysis. So what do I mean by that? What is a fractal? So to understand that, you have to understand the notion of dimension. So when you think of dimension, you kind of think of going to the IMAX and putting on 3D glasses, right? So that's kind of the dimension that you think of, with the 3D sticking out of the film on there. So that dimension is basically the Euclidean dimensions. It means if you wanted to define every point in a set, kind of how many axes do you need? Right, so if we say a point is 0 dimension and a line is 1 dimension, right, then your square is 2, of course, and your cube is 3 dimensions. So that's one way, and that's the way that fits our intuition pretty well, but not the only way to define dimension. Another way is looking at topology, sort of looking at shape. And that way you're saying, instead of looking at the axes, you're saying, what would it take to break my set into a subset on there? So we can define the point as 0, and then we can define any other set as 1 plus whatever it takes to break that completely. So if I have a line, I'm going to break it into a line segments, I just need to put a bouncy point in the middle there. Okay? So then my line is dimension 0 plus 1. Similarly, I can take that line and use it to break my square into subsections. Right? So now it's 1 plus 1 is 2. And I can take my plane and separate my cube. Okay? So for these items, dimension Euclidean and dimension topological are the same, but what about for an item like this? So that is a Koch curve. It is a fractal object that's created by iteratively deforming a line on there. So if I wanted to use dimension, I would need an x and a y-axis, right? So by Euclidean, it's dimension 2. But by topology, I can take a single line and fold it and cover that entire structure. So by topology, it's dimension 1. So what if there were a way to get a non-integer measure of dimension that characterizes how foldy, curvy this item is? And that's basically what this fractal measure is doing. So it turns out that for that curve, you get a number of 1.26. And there is a mathematical way that you get that, which I'll go through quickly. All you're doing in this case is looking at a scaling property. So you're saying if I zoom in on an object, how much new information do I gain? So this ratio of magnification, size magnification, is how you compute this. And so I'll skip the math since we're going quickly. So this is a fractal landscape, and so it is generated using a similar technique. So you get very biological looking, very natural looking structures by using these fractal properties. And so you can imagine in the planes here, that the dimensionality is closer to 2 because it's flat, more like a planeless. But up in the mountains where it's more bumpy and curvy, the dimensionality is closer to maybe 2.5, 2.6. If I had an infinitely curvy, bumpy, completely space-filling mountain, it'd be dimension 3. So I want to take those same tools and apply it to the bumpy foldiness of the brain. Okay, so a couple of features. So what I've done is I've taken a real two-dimensional slice of the cortex. I've extracted just the cortex, everything else is gone, created an idealized version in the middle, and then if I say things like change the thickness, what happens to complexity? And so as thickness goes down, complexity goes down. I can change the number of folds and curves on here, so as the number of folds and curves goes up, so does the complexity. So you get this nonlinear summation when you have increasing thickness and increasing foldiness, or gyrification is on there. So the most complex structure is the one with the most curves and the thickest cortex. Okay. So given that intuition, question is, well, what makes the brain fractal? So it turns out that it is the folding that makes it fractal. So if you look at brains across the animal spectrum, whether they're folded or not, you get interesting features. Okay. Of course, this is a cat brain getting more folded, monkey brain, even more folded. Anybody know what that is? I heard something over there. No? Okay. Anybody want to stab at it? Yeah, okay, well, it's a boar. Yeah. So it's a big pig. Yeah, so pigs are smart. Big folded brains on there, good. Of course, our brain, then check out the elephant brain. Super folded on there, enormous. Okay, good. So if you look at the ratio of surface area to volume for these animals, the ones that are smooth have a flat relationship. The ones that are folded, there's a power law that relates them that is a similar way to getting frontal dimension out there. So what I've done is I've taken the MRIs of the brain. I use some technology that I learned while I was in Boston to extract the surfaces. And so what you're looking at here, the upper one is the inside of the cortex, and the lower one is the outside of the cortex. And so I can create these nice models of the cortex from FreeSurfer. And those models are made up of about 200,000 points and polygons on there. And I can compute the complexity of that three-dimensional structure. And so this slide is designed to give you a little bit of intuition. So the brain that is the thickest and the most folded has the highest number, and the one that shows the wider sulci, sort of the thinner cortex, has the lower number. It's not a ginormous, I'm using words like ginormous now. Yeah, I never used that word until I think there was a movie with the giant hero lady. This is your ginormica. Anyway, still a cool word. So the brain, so it's not a very large dynamic range on here, but there's enough range to get some sensitivity on there. So this is looking at the complexity of the brain across the lifespan. So this is what is normal. So on the x-axis is the age of the subjects. This is from also the Dallas Lifespan Brain Study. So 312 individuals in that one. And so you can see that there is a fairly linear decrease in complexity across the lifespan, and this is just in the normals, and that there's increasing variability as people age. We don't all age the same way. And if you focus on the right side of this, so here's kind of the money slide. So can I use this to separate normal from Alzheimer's disease, and with how much power? And so this is data also from ADNI, and it says that individuals with Alzheimer's disease have a lower complexity of their brain, that's this checkerboard box, than those who are normal. So that was the proof of concept right here. And we've now been able to take that whole brain number and apply it on a regional basis using FreeSurfer, and so I can get 30 regions in each hemisphere. And so the brain doesn't change uniformly everywhere. There are some places that are more vulnerable, and so having this data sets up the next analysis of saying, how does this compare to aging? There are technical issues in that the data from Dallas was not phantom normalized, and I can't compare it to ADNI directly, and so that kind of sucks. But we're working on that. We're collecting new data to answer this question better. Okay, so then why are we doing all of this? What is the point, and how can we use this to help understand what's happening with Alzheimer's disease? So we know that the current treatments are primarily symptomatic. They help, but they don't reverse. They don't change the slope too much. We need better therapies. How do we get better therapies? Is through clinical trials. Okay? So clinical trials that use neuroimaging biomarkers, there is certainly a hope that this can help you be more specific. It can help you to have lower numbers of patients needed to generate an effect size. You're hoping to get more reliable measures on there. So neuropsych measures between paper and pencil testing are important. We've got to have them, but there's a lot of variability in how they're done, and that's why we have to record them. We have to get. I visited the center this morning, and I think every third patient gets a video, and different. Okay, on the third visit, I guess everybody gets a visit, right? Yeah, and so 2 different highly trained, experienced clinicians have to rate and come to an agreement on what's happening. So it's difficult to get quality. I mean, it's a lot of work, I should say, to get quality neuropsych data. So if we can use neuroimaging, it can help to combat some of that variability. And it also serves as a measure of success. If you give somebody an amyloid-lowering agent, you better show that they actually lowered amyloid. And so neuroimaging is a way to do that as well. Okay. So the clinical trials. So why do we do research studies? Okay, so the only way to know if your new intervention, your new study, your new drug worked is to do carefully controlled, prospective, randomized, placebo-controlled trials on there. So those are difficult, and you need people to be engaged on there. And if you want to extrapolate results, you better have a diverse population to extrapolate to. And so ultimately, that's the only way to demonstrate that what you're doing is successful or not. And so identifying patients is a real issue. And part of the problem for identifying diverse patients is that there is a history of inequity. And I think it's important to address and to be aware of some of the clinical trial inequity that's happened, because the history of clinical trials is replete with what we would now consider rather unethical behavior. And populations that have less of a voice tend to be more exploited. There have been a number of studies, say the Tuskegee Airmen study is a famous example, where individuals were allowed to have syphilis advance despite having what was known to be a good treatment for it, because they wanted to see what happens. And so the group that was left untreated were dominantly African Americans. So there are several other kind of important examples of that as well. But the good news is that that cannot happen anymore. That the process for clinical trials has evolved dramatically. And so it's important that when you're recruiting patients, that you make sure that everybody knows the possible side effects of what's happening, time, risks, and benefits, that they know that research is voluntary, and so there's no obligation for it, but definitely encourage it. So the ethical principles that we're adhering to now, 3 important ones. So respect for persons. So you have to treat individual with respect. You have to treat people as autonomous. In cases where individual may not be able to give consent, it's important to have their assent. So they may not be able to say, I understand all the details of your trial, but they can say, yeah, I want to participate in what's happening, and then have a loved one, have somebody else give the consent in more detail. So I know certainly in Utah, and I'm sure here, you have to have an informant come with you in order to do these studies correctly. And so having that informant is a critical piece of this. So beneficence. So making sure that there is a clinical benefit. So you can have the most fancy, complicated study, but if there's not a clear benefit to society, then is it worth the risk to the individuals? So, and of course, justice, and this is where this center is so important, is trying to make sure that this is treated fairly and is assessing everyone so that everyone can share in the benefit of those trials. And that's why the Institutional Review Board is so important. So every study, before you can start, has to go through the Institutional Review Board, and that's not an easy process. There is an informed consent document that must be very, very carefully worded to describe what you're doing, why you're doing it, how you're doing it, when you're doing it, who you're doing it to, what you hope to gain, and explain all of the procedures in there so that when people say yes, they can do that with informed consent. Written informed consent is absolutely critical. And that has to be approved by the Institutional Review Board before you can even start recruiting anybody. And sometimes that can take months. I hope yours is a little better, but it's long. I think it's a long process. And there are efforts to try to create central IRBs and those types of things to get things done faster. But with the right IRB, they are really our advocates. They are trying to help us do the research as safely and ethically as possible. Good. Right, so informed consent, as I mentioned before, so you want to ensure that it's voluntary, that people understand what's happening, that they have the information that they need. Okay. So why do people participate? Of course, you want to make sure that you're highlighting the benefits of giving back to society, that there are that the current treatments need to be developed. Sometimes there is compensation, but you can't use compensation as an incentive. You have to be very careful about that. So it's designed to really say, you are giving of your time and your effort. We recognize that. Here's lunch and here's some money for gas, those kinds of things. So using it as a compensation is good. Using it as an incentive would be a bit unethical. If I offered everybody $1,000, and then obviously we don't have the money for that, but you can imagine there being many people who might enroll in the study just for the money and not because they are actually interested in the science. And so being coercive is a negative thing. Okay. Good. Yeah, so these are the types of things that you should ask, or anybody being involved in research should ask. So, what's the study about? What are the goals? Who's sponsoring the study? Is this an investigator-initiated, or is it sponsored by a pharmaceutical company? I think it's not bad either way, but you should just be aware. And then what are the benefits? What are the inclusion criteria? Every study has its own set of risks and benefits and time obligations. Important to be clear about that. Okay. All right. So to wrap it up here, so clinical trials, of course, are the only way to get to those results. We need more people involved. We need more advocates. And I hope that everyone in this room can serve as an advocate for that, because we need everyone in this room to serve as an advocate. Be very careful how you follow the guidelines and protocol, and I probably have a stack of protocol deviations to go through when I get home, so this is part of being in clinical trials. Is there's a ton of paperwork, but it's done so that we're all being careful and doing the same thing and can then extrapolate results at the end of it. Make sure that you're ensuring the well-being of all your participants. Yeah, it's a very active area of participation, and again, we need your help. So with that, I will stop and take your questions if you have any other ones. So.